Perfect. Okay. I will try to make this as clinically relevant and painless as possible, bi'idhnillah. This is what I'm trying to cover, basically. We'll talk a little bit about epidemiology because it's very important. If we understand the scope of the problem, we can actually understand the better way to tackle it. Pathophysiology ala sari', disease burden, prophylactic approaches, therapeutic approaches, perioperative management, which is something that we face a lot in our patients, and then duration of therapy, and then last thing is just what we have down the horizon. What do we have to look forward to? So epidemiology of cancer-associated thrombosis, we know about 20% of VTEs, or venous thromboembolisms, are cancer-related, right? So again, 1 in 5 patients with a thrombosis has cancer. It's either cancer that we already know exists, but a lot of studies have showed that this cancer can actually be occult. So VTEs can precede the diagnosis of cancer by months to years sometimes. It depends on the type, stage, and course of disease. The risk tends to peak in the first 3 to 6 months of diagnosis, and that's usually when it's most volatile in terms of the disease itself. The highest incidence tends to occur in brain cancers and pancreatic cancers, and it's the second leading cause of death in patients with malignancy after disease progression itself. If we look at the pathophysiology, I think Virchow's triad, we all know it very well by heart, but generally you have the vessel wall injury with all its different causes, from surgery to vascular remodeling, to catheter placement, to instrumentalization that we tend to do in these patients, to vascular damage itself. You have venous stasis with its prolonged bed rest, the decrease in your ECOG or performance status, edema, vascular compression from the tumor itself, or structural defects due to the cancer and its anti-angiogenic effects that a lot of these tumors carry. And then you have your hypercoagulable state from the various causes of it as well, from problems with your upregulation of tissue factor, to procoagulant states, to comorbidities, to circulating cancer cells. So tumor thrombus is a thrombus at the end of the day, right? So it gives you the same effect down the line. And then the general or overall inflammation that happens to patients. And when you have 1 or 2 or 3 of these factors, you end up having a thrombus at the end of the day. I'm not going to go into detail of this, but this just wants to show the complexity, basically, of trying to figure out what leads or what causes cancer-associated thrombosis. You have things that have to do with your procoagulant activity and the effects of the malignancy and the inflammation on your coagulation cascade itself. You have issues that have to do with your NETs or neutrophil endothelial entrapments, right? You have things that have to do with the tumor itself and the tumor-released procoagulant factors or mimickers. And then you have things that have to do with the overall inflammation and the decrease in the fibrinolytic activity of the tumor. And then obviously vessel injury and all these other parts of it. Okay, so how do we assess a patient and what leads to bleeding risk versus thrombotic risk in patients? It's always in this swinging pendulum or this seesaw, and eventually one of these ends is going to tip over, and it depends on which end your patient's at. But cancer type, cancer stage, type of surgery, other factors driving the patient's underlying bleeding disorders, right? So patients with hemophilia, patients with factor deficiencies also get cancer, and then that becomes just another layer of complexity in managing these patients. If we look at the genetics, we do understand that genetics in oncology or solid tumor oncology actually play a major role in terms of which patients get more thrombosis. So ALK positive and non-small lung cancers, VTE incidence up to 47%, right? EGFR, 35%. KRAS mutations, JAK2 mutations, which we already know and we're very aware of, IDH1 and IDH2 and ROS1 mutations. All these things have different levels of thrombogenic activity, basically, in patients. And then if you move from that and look at the chemotherapies we give patients, those also affect our ability or our thrombogenic potential for malignancy, right? So we know for a fact, for example, that platinum-based therapies, taxanes, cyclophosphamide, most of our IMiDs for myeloma, aromatase inhibitors in breast cancer patients, BCR-ABL or TKI inhibitors, even the new PD-L1 and PD-1 inhibitors also promote your thrombogenesis in these patients. So all these things come and play a role. So the cancer itself plays a role, the patient's performance status plays a role, and then the therapies we try to give this patient to cure their cancer also adds to the burden of disease. We know here, we looked here at the incidence of PEs or pulmonary embolisms in cancer cohorts, and they looked at it between 1997 and 2017, and they found that the incidence of pulmonary embolism in these patients, and that's a red line, went from 0.32% up to 2.3% in the 10-year mark, right? In addition to that, the incidence of DVT did not change much. So the question that comes to mind here is, are we just getting better at detecting these PEs earlier? How much of this cohort was actually incidental PEs or subsegmental small PEs? We don't know, because this was a retrospective analysis through Sears data, but we do know that the incidence is going up. If you look at the different cancers by local, regional, or remote METs, you'll find that, again, these cancers differ across the board. If you're green and you have distant METs, your risk of thrombosis is high. But you'll notice for a fact that, for example, uterine cancers or GU malignancies are very high in females. You'll find that pancreatic cancer is the highest of them all at the far end over there across the board. Breast cancer, although it's the most common malignancy, is actually not as thrombogenic as the rest of them, and prostate cancer is similar, right? So, burden of disease, this is across, I think we have a good understanding of it as hematologists and providers, but it affects, we know that thrombosis carries a higher morbidity for patients, while bleeding carries a higher mortality, right? But as we move towards more higher tertiary care center care for malignancy patients, we actually are very good at managing bleeding for the most part. So then that leaves us with the morbidity that's associated with thrombosis that now takes a larger burden of disease from us. But it will increase your hospitalizations, it will increase the associated morbidity, it will worsen your survival, it will delay your cancer treatment, it will worsen your quality of life, it will affect you across the board, or affect patients across the board. All right, so let's talk about prevention first. Who should receive primary prophylaxis for cancer patients? This is the timeline of what we've developed so far in terms of, or the trials so far that we've had for cancer therapy in terms of prophylaxis. The blue are solid tumor malignancies. The red are hematologic malignancies. So Throlley, which was in 2016, was related to lymphoma. SAVED and IMPEDE VTE were related to myeloma. And then across these are different scores that have been studied and validated. I think the most infamous of them all is the Corona score, which was originally published in 2008, and then validated after that on multiple occasions, and then updated, obviously. But we have a good number of data studies that tell us or talk to us about cancer. Corona score, just very quickly, it heavily relies on the site of malignancy. So stomach and pancreas have the highest rates, and they're considered very high risk with 2 points. And then lung, lymphoma, GU, bladder, and testicular cancer are considered high risk. And then chemotherapy platelet count, or pre-chemotherapy platelet count, hemoglobin, leukocyte count, and BMI, and it gives you a scoring point. If you're low and intermediate, you have relatively the same risk of thrombosis, but if you're high, which is anything above 3, then you're automatically someone that should receive prophylaxis. IMPEDE VTE, just because we want to cover myeloma here, this one basically looks at different variations of myeloma risk factors themselves. There's some negative risk factors at the bottom for race, ethnicity, and use of aspirin or low molecular weight heparin in prophylactic matter. And again, you calculate the score. If you have a score of 8 or above, you're considered high risk with a risk of thrombosis of 15%. So, what do we have in terms of clinical trials that tell us or talk to us about prophylaxis in cancer-associated thrombosis? We've had, starting in 2009, 12, and 15, we've had 4 trials that looked at low molecular weight heparin and have proven that low molecular weight heparin is a fantastic option for prevention of DVTs in patients. And then when we moved to the DOAC era, in the 2010s, I guess, and afterwards, we have the Cassini in 2019, the AVERT VTE, and then the Melexat looking at the Pixaban. And these trials basically have proven that DOACs are just as effective and almost just as safe in terms of use for VTE prophylaxis in patient populations with cancer. This is a quick review of AVERT and Cassini. I think we've been using these medications now for long enough that we know this data subconsciously to a certain extent, I hope. But AVERT looked at apixaban, Cassini looked at rivaroxaban. They basically involved most of the malignancies, but for apixaban, they took out the acute leukemias, transplant, and myeloproliferative neoplasms. The primary outcome they were looking at were incidence of DVTs. And the secondary outcomes, or the secondary outcomes were mostly related to major bleeding, because that was a very big concern for us when DOACs first came into the market. And then they looked at venous thromboembolism. You'll notice that apixaban had a rate of about 4.2% in the treatment arm versus 10% in the placebo arm. Rivaroxaban was 6 versus 8.8%. but the bleeding risk in apixaban was a little bit higher than it was in rivaroxaban. And again, we're comparing apples to oranges, but this is a general data from the trials that we have. Then we had a very nice systematic review that was done by a bunch of the kind of lead world experts, I guess, in cancer-associated thrombosis, including Khorana and Mark Carrier. And we found that the relative risk of DOACs reduced the risk of any VTE by about 44%, and they reduced the risk of symptomatic VTE by about 42%. And the number needed to treat to gain this benefit is 40 patients. So for every 40 patients you treat prophylactically, you have one gain or one benefit, or benefit gained for one patient. If we look at the major bleeding risk that we look at, they divided it into major bleeding and clinically relevant non-major bleeding based on the ISTH scoring or ISTH definitions. And we find that for patients with DOACs, there was a 96% higher relative risk of major bleeding compared to placebo. And there was a 28% higher relative risk of clinically relevant non-major bleeding compared to placebo. But the number needed to harm is 100. So for every 100 patients on DOACs, you get one patient that suffers one of these consequences. And then obviously patients with a higher Khorana score derive the largest absolute benefit. And again, these are patients mostly with pancreatic and gastric malignancies. So take home points from prophylaxis. Validation tools, we have a lot of them, right? These are just a handful of them that we talked about, or a couple of them we talked about. So familiarize yourself with one or two and use them, utilize them often. Khorana score is the most widely used. Myeloma has the IMPEDE VTE scoring. Cancer-associated thrombosis risks are very dynamic, so you actually need to assess your patient frequently, right? And this part is this job or this responsibility falls on us as hematologists, but also to a certain extent, or a bigger part of the responsibility falls on our colleagues from oncology, because they tend to see these patients more often. But this is a very dynamic scoring system. You have to balance your risk versus benefit. You have to choose the most appropriate option for each patient. If you give a patient a medication that they don't want to use or cannot use, they're just not going to take it, right? So sometimes the ideal option from an evidence-based perspective is not always the option that's best for your patient. So you have to kind of weigh the risks and benefits. Keep in mind that in head and neck cancer, swallowing may be a problem. Absorption in some gastric cancers may be an issue. And then obviously precision medicine, as we're involving or validating new scoring tools, we're going to look more at prediction models and cytogenetics. If we take a look at therapeutic approaches now, so the question becomes, we have a clot, it's diagnosed, then what do we do, right? The journey here in evidence-based medicine for treatment, you start similarly with low molecular weight heparin, and we proved it through multiple studies starting at 2002, and then we moved to DOACs for the effectiveness of DOACs over low molecular weight heparin, and this is where we have our Hakusai, SELECT-D, ADAM-VTE, Caravaggio, Canvas, and many more. And then finally, we move to the ongoing trials or trials that are coming up. But our DOACs, we have actually proved that they're just as effective as low molecular weight heparin with a slightly increased risk or potential risk of bleeding in these patients. This is a study that focused on the therapeutic trials for DOACs and compared them to low molecular weight heparin. And you notice that DOACs significantly decreased the risk of recurrence with a relative risk of 0.67. It had a non-significant increase in major bleeding, and major bleeding is any bleeding with 2 grams of drop of hemoglobin, ICU admission, or transfusion of more than 3 or 4 units within a 24-hour period. But there was a significant increase in clinically relevant non-major bleeding, and this is basically a bleeding that brings the patient to the ED. They may need to be admitted, but it's not something that's life-threatening, right? And this is the balance, again, this is the balance that we have to give or take. The patient can take something, take it at home, take it in a pill form versus injections once or twice a day, but there is an increase of some bleeding. So choice of DOAC, what do you give? I think choice of DOAC relies sometimes on what you have available in front of you, right? Because the differences are not that major. But if you were going to choose and look through it, you'll find that when they compare the apixaban to endoxaban, rivaroxaban, and then low molecular weight heparin and vitamin K, you'll clearly notice that vitamin K across the board is now out of the game. It clearly favors oral DOACs, but the safety profiles of DOACs tend to differ, right? Apixaban and rivaroxaban are absorbed in your stomach and duodenum, but rivaroxaban tends to have a little bit more absorption in your duodenum and early jejunum. So if you have a problem with your gastric mucosa, or if you've had a gastrectomy, then you may want to rely slightly more on rivaroxaban. The dosing regimens differ. Some patients can never remember to take something twice a day, so there's no point in trying to give them something when they're going to be only partially compliant on it. And then finally, the risk of major bleeding was lowest in apixaban, but we're talking about point percentiles of difference, right? So overall, I think they're very comparable when you talk about rivaroxaban to apixaban. Brain tumors is always a big thing. We know that brain tumors have a higher, they're highly vascular, right? And that's whether they're primary or metastatic, and so the increased risk of bleeding or the concern for bleeding is higher. But there was a very nice trial that just came out in 2025, and it looked at patients receiving DOACs, and they found that they had a statistically lower risk of intracranial hemorrhage compared to low molecular weight heparin. And this was actually, they looked at it and they found the largest benefit in primary brain tumors. And then when we looked at risk of intracranial hemorrhage with DOACs in brain mets, we found that adults with solid tumors who actually developed thrombosis within 6 months of brain mets, they matched them 1-to-1, and they had about 4,200 patients. And the results showed that DOACs had a lower risk of intracranial hemorrhage. They had significantly lower rates of ICU admissions, and all-cause mortality within 12 months was basically 42 versus 48 or 49% almost in the DOAC group. So again, very comparable. This gives me the safety or the comfort of using DOACs in patients with whether it's primary brain cancers or brain mets. Take home points here, every event requires treatment. We often get questions from our colleagues in radiology and surgery. If you find it, even if it's incidental, you actually have to treat it. You have to treat for 3 to 6 months based on location, clot burden, and cancer type. DOACs are generally non-inferior to low molecular weight heparin, but again, look at swallowing, absorption, financial toxicity. Luminal cancers, no matter what you do, they're going to bleed more, especially things that have to do with the kidneys, renal pelvis, ureters. They may have a higher risk of bleeding overall. DOACs are generally comparable in terms of safety and efficacy, and apixaban has less major bleeding overall. Perioperative management, very quickly. So I just put an algorithm here. We often get patients where we diagnose them with a PE or DVT as they have a diagnosis of cancer, and the difficulty becomes, is the surgery that's is planned, is it curative or not? And that's usually the biggest question I have for our colleagues from oncology and surgery. If the procedure is considered curative, then we have to be very flexible with them in terms of getting the patient to surgery as soon as possible, which is very different than if the procedure is considered for debulking purposes only and it's palliation in terms of treatment. But if you have a diagnosis of acute VTE, is a surgery considered urgent? And again, whether it's urgent from a surgical stabilization standpoint or whether it's urgent from a therapeutic standpoint or curative intent, to me, I tend to weigh them the same. But if you can delay surgery for 4 to 6 weeks, then by all means, let's try to do that. If you're not able to delay, then we minimize interruptions. We consider the use of low molecular weight heparin or unfractionated heparin, and you shorten the duration when they're off of anticoagulation. Usually when we talk to our colleagues from surgery, we have to be very concrete in what we give them. So minimizing interruptions is not something they can quantify, right? So we usually tell them to keep them on heparin for 4 hours before they push them into the OR, and then restart it within 8 hours post-op at the most. They can push it to 12 hours if it was a major surgery and the patient has a lot of drains. And then we try to give them multiple options in terms of how much heparin they provide the patient so that they can actually choose what they think is best in a multidisciplinary fashion. If we're looking at management of a bleeding patient who has a thrombosis, heavy menstrual bleeding is very common in these patients, and we often can manage them with TXAs or something similar to that. We've had to have some patients on some form of contraception if they're young and their primary cancer is not uterine or ovarian, if they're protected well enough through anticoagulation. But if they're having major bleeding, then you actually have to withhold anticoagulation, consider an IVC filter. It's almost never the correct answer except for patients with major bleeding episodes. And IVC filters have to be very time limited, so you have to understand exactly when it was placed and exactly when you plan to take it off, which is very different than patients who have this non-major bleeding that is bothersome and it continues, and they'll keep calling you back about the patient, but it's not as life-threatening, obviously. In these patients, you can sometimes lower their dose of anticoagulation slightly, so put them down into intermediate dosing to try to mitigate that. Duration of therapy, so we agree that any thrombosis is 3 to 6 months in a VTE or until cancer cure. But then what happens beyond the 6 months? Up until Q3 or Q4 of 2025, we used to treat them indefinitely with therapeutic anticoagulation if they have metastatic disease. But then we had the API CAT trial, which looked at extended reduced dose apixaban for cancer-associated venous thromboembolism. And in this trial, basically, it was randomized, double-blinded. It was a non-inferiority trial, and it looked at consecutive patients with active cancer and a proximal DVT or PE who completed 6 months of anticoagulation, and then they were randomly assigned in a 1-to-1 ratio to either get apixaban at 2.5, which is the reduced dosing prophylactic one, or 5 milligrams twice a day for 12 months. And they looked at the primary outcome was centrally adjudicated fatal or non-fatal recurrent venous thromboembolisms, and they tried to do that to control for variables as much as possible. And then the second thing was clinically relevant bleeding. And this is what it showed, basically, that the primary efficacy outcome, of which is recurrent thromboembolism, was not that different between the full dose and prophylactic dose of apixaban, and it was clinically significant. If you look at major bleeding, yes, major bleeding was slightly higher in the full dose apixaban, but the numbers were not high enough, basically, to reach statistical significance. And if you look at clinically relevant non-major bleeding, which is the annoying bleeding that just brings the patient into care but does not threaten their life as much, you'll find that the difference also was not significant and the numbers were not that high. Death from any cause in these two patient populations was also not significantly different. So what do we get out of the API CAT trial? That after 6 months of therapeutic anticoagulation in patients with cancer, apixaban 2.5 milligrams BID was non-inferior to the full therapeutic dose of 5 milligrams over a 12-month period, and it reduced the clinically relevant bleeding risk in these patients. So I think now most of us shifted our practice, or I hope most of us shifted our practice to drop them to their prophylactic dosing after 6 months. Last thing is down the pipeline, and I have less than 3 minutes. So we have the abelacimab, and it's a monoclonal antibody that dually inhibits factor 11 and 11A, and it's a monthly subcutaneous injection. They've tested this drug already in total knee replacement patients, and they faced it off against enoxaparin in ortho patients, and then they tested it in a phase 2b against rivaroxaban in AFib patients, and the drug actually performed really well in these two groups. But now we're moving it towards cancer-associated thrombosis, and in these patients there's the ASTER trial, which is a phase 3 trial currently ongoing, comparing it to apixaban for treatment of cancer-associated thrombosis, and then there's the Magnolia trial, which is comparing it to dalteparin in high bleeding risk patients with GI and GU cancers where DOACs are generally not recommended. So they're actually very bold in approaching this medication. They took the patients that we are most concerned for starting DOACs at, and we're going to wait for the results of this trial. Thank you very much. That's all I have.